All right, good afternoon, everybody. Can everybody see the screen? Perfect. All right, sorry, I keep on looking. I have two different screens, so my face is going in different directions. All right, so my name is Christina Lamb, and I'm a dermatologist at Boston University, Boston Medical Center. And I'm really excited to be here today with Dr. Gonzalez to talk to you all about skin manifestations and skincare in scleroderma. So I'll be talking at this session with Dr. Gonzalez, who has actually been the rheumatologic dermatology fellow, so my fellow for the past year, and has spent a lot of time with me learning about skin manifestations of various connective tissue diseases. So I'm very excited to welcome her and have her here with me today as well. Okay, so as you all have probably heard during various lectures that you've had over the last few days, scleroderma, also known as systemic sclerosis, is an immune-mediated rheumatologic disease that is characterized by fibrosis of the skin, so skin tightening, and various internal organs. And on the right with the schematic here, you can see kind of generally speaking, I would say not in a lot of detail, kind of how we think about the pathophysiology or why scleroderma occurs. And so we think that there's a genetic predisposition, so certain people are more predisposed than others in combination with a trigger of some sort. And that may be environmental or certain viruses, an infection of some sort. And that triggers a variety of processes that then leads to what we see as scleroderma. And in general, we talk about three main biologic processes that contribute to scleroderma. And so the first one being blood vessel abnormalities or vascular dysfunction. And then we see, of course, fibrosis, and that's the one that I think most people can tell. So that's where there's an overproduction of collagen or it's fibrosis that occurs inside the skin, and that leads to skin tightening. And then there's also an immune system dysfunction, inflammation, and autoimmunity, which means that there are certain cells that are produced by your own body that attack certain organs and the skin as well, and that leads to what we see. And so those are kind of the three main processes. In terms of manifestations, there are, of course, the systemic manifestations or the internal organ manifestations. And then what we'll be focusing on today is the cutaneous manifestations. And, you know, you've heard in various, and there have been some excellent sessions over this past weekend about different internal organ manifestations that that patients with scleroderma can have. And so pulmonary involvement, things like interstitial lung disease, pulmonary arterial hypertension, kidney involvement, like renal crisis, for example. Many patients will experience gastrointestinal problems, things like reflux, bloating as well, and then a variety of musculoskeletal disorders like joint inflammation, muscle pain, and then the skin findings, which we'll talk about. And so as a general approach for us as dermatologists, when we see a patient with scleroderma, and in fact, most physicians who assess scleroderma, importantly, at the beginning, when we examine patients, we want to assess their disease subset. And so you've heard about these different types of disease subsets in the other lectures as well. And so just to recap, in general, we talk about diffuse, limited, and then the CNA. And the reason why this is important is because in general, there's different prognostic implications depending on how extensive the skin disease is. And that also leads to certain organs that are more involved or less involved, or certain organ manifestations as well that we want to be more aware of. And so the disease subsets are determined by the extent of the skin fibrosis. And so the cutoff tends to be, generally speaking, I would say, you know, things are not always black and white, but generally speaking, it occurs at the elbow area and then at the knee area. And so diffuse scleroderma happens when the fibrosis is occurring a little bit everywhere, all over the body. So we talk about the extremities being involved, the head being involved, the face, and then also the trunk area. So we'll see skin tightening on the chest, on the back, and on the abdomen. Whereas in the limited form, the name says it, it's more limited. And so the cutoff occurring at the elbows, we see more distal, or the parts of the extremities that are further away from the center part of the body. Those are the parts that are involved. So we talk about fingers to elbows, and then toes to knees, as well as the face. And then CNA means that actually the skin, we don't really see any fibrosis in it, but the patients have internal organ manifestations that are very classic for scleroderma. And then once we've determined kind of the disease subset in general, where we're going with the disease, we want to determine which organs specifically are involved. And then we kind of talk a little bit about examining patients in terms of their joints, in terms of their lungs, their heart, as you can see the little diagram there, kidneys, the gastrointestinal tract, and then their skin. And so we'll do a very good history and physical exam. And when you go see your doctor, you know, a lot of you have experienced where they kind of pinch the skin. And so we call that the modified Rodman skin score. And what we're looking for in that case is the degree of skin tightening that you have, because there is a range. Some of it can be looser. And so where you can feel some tightening in the skin, but there is still the ability to pinch the skin. And so that skin is not as tight, for example, as a patient who has much tighter skin where the ability to pinch it is not there or very limited. And then we also order a panel of blood work looking for different organ involvement, inflammation in the skin, muscle involvement. We look at the kidneys as well. And then we also order in general imaging, pulmonary function tests, that's the PFTs. They're looking for lung function, high resolution chest CT, so that's a CT scan of the lungs. And then also echocardiograms, that's the TTE, looking for cardiac or heart involvement, and also the pressure occurring in the vasculature. And so in terms of now moving on to the cutaneous manifestations, we're going to talk a little bit about the most common ones that we see from a dermatologist perspective, and then how we treat them, sometimes how we can prevent them. And you'll see that, you know, the general theme is there are several cutaneous manifestations that we see. A lot of them can be quite debilitating, and it is, of course, what patients see the most, and what can bother them a lot, because it is the part of the body that we present to the world. And some things we can treat better than others. And so we'll talk a little bit about that. So these are the various cutaneous manifestations that we'll be talking about today. The most prominent one, and the one we think about the most associated with scleroderma, of course, is the fibrosis, as I mentioned before, and the skin thickening. We also have Raynaud's phenomenon, and then skin ulcers, telangiectasis, which are dilated blood vessels. We see pigment changes in the skin, calcium deposition, and then itching and dry skin. And so we'll be talking about all of those things. And so to start off with, fibrosis, or skin thickening, typically has 3 phases in the way that it presents. So the initial phase is the inflammatory phase, so where there's more inflammation happening in the body, and this will typically present in the skin as swelling. And the most common area where we see this, and the area where patients will experience this the most, is in their hands. And so they'll initially complain about having puffy fingers, puffy hands, sometimes a little bit of difficulty making a fist because of the swelling that's occurring in their hands, and then in their fingers and in their hands. And then as time goes by, the swelling will kind of make way to more induration. And so that means that the skin will become tighter. And then after a while of being very tight, then we end up in the kind of more late stage fibrosis or changes of the skin, where you see more atrophy of the skin. And that means that there is more kind of loss of volume of the skin. And so the photos here are showing you different manifestations and different places where this fibrosis occurs and what it typically will look like. And so as you can see on the photo with the fingers up on the top photo on the left, this patient has contractures of the fingers, meaning that the skin has been indurated and atrophied in such a way that the joints are no longer as mobile as they used to be. And so patients can find that their hands are fixed in a certain position. And you can see that that's occurring over there. And you can see that the skin is a little shiny and atrophic, meaning there's been some loss of volume. And that's characteristic of the induration and the fibrosis of the skin. Now, on the bottom left, what we can see is a patient who has her mouth open, and we call that oral aperture because that's how wide a patient can actually open their mouth. And when the skin around the mouth and around the face is tight, the oral aperture, or the ability to open the mouth, is actually decreased. And we can measure that actually and follow that over time. And you can imagine the functional issues associated with that when the patient cannot open their mouth as well as they would like. And so that can affect eating as well as speech and things like that. And on the right is a photo showing what we call in dermatology kind of characteristic facies associated with scleroderma. And so this is more of a late stage look of scleroderma, so someone who's had scleroderma for a long time. We call it the pursed lips. And so where there's more prominent wrinkling, where you can see it around the lips, and then also where the nose is a little bit more pointy. And those are signs because the skin has kind of atrophied a little bit over time. And that's what a characteristic look of late stage scleroderma looks like on the face. Now, in terms of treatment of the skin fibrosis, unfortunately, we don't have a particular agent, one agent that's proven to be effective. And there's a huge degree of variability in terms of the skin fibrosis for every patient. So it's very individual. When we talk about limited skin disease, so where, it's occurring at the hands, the elbows, the face, and then kind of the lower parts of the legs, but not the trunk area. Sometimes it can be pretty mild, and patients don't really have a lot of functional disability associated with that. And so sometimes what we do with that is it doesn't really, we don't necessarily need to treat that. We can just choose to monitor and see whether the disease will progress. There's also a really interesting phenomenon that happens in a certain percentage of patients with scleroderma where the disease may get better by itself, and the skin may soften without any systemic therapy. And so sometimes it's hard to know when we see a patient for the first time which direction they're going to go in, whether it's going to progress really, really quickly and become really tight, or whether it's going to become tight but then going to improve by itself. And so for patients that have active diffuse skin disease, and this is of course taking into account all the investigations we've done, and if there is no major organ disease, because we definitely target our treatments towards that if that was the case, then there are different treatment options, 3 in particular we think about. So as I mentioned, because some patients will improve spontaneously, we can choose to do serial observations, so short-term monitoring for 3 months, see how they do before we decide to put a patient on systemic therapy. There's also the more traditional immunosuppressive anti-metabolite therapies such as methotrexate, mycophenolate mofetil, that we can choose to give patients who have tightening of the skin if we want to treat them. And these are agents that have been shown to help with the skin tightening, the skin fibrosis, in addition to other types of manifestations as well if patients have those, like lung involvement, for example, with mycophenolate mofetil. And then we reserve things like cyclophosphamide, which is a pretty potent immunosuppressive therapy for patients that have very diffuse, active, rapidly progressive skin disease, often in association with other organ involvement like lung disease. Rituximab as well is something we can use, which is a biologic agent, a monoclonal antibody against the B cells that we can use for very significant skin disease as well as lung disease. And then sometimes we will also use systemic corticosteroids. Typically, we try to use low doses, particularly in patients with scleroderma, because if we use high doses, there is a higher chance of having kidney problems with that. So we try to limit the strength of the dose that we give. And then for patients that have very, very significant skin disease, stem cell transplant is something that has been described. It's definitely not first line, but for patients that have organ involvement and skin disease, that may be something we want to go for. But the treatment can be quite involved because the regimen that we use for stem cell transplant can be quite immunosuppressive. And then there's a host of novel immunosuppressive therapies or biologic therapies that have been studied and that are currently being used in clinical trials that target very specific areas in the immune system that we think are involved in the pathogenesis or the kind of disease process, the biology of scleroderma. And we think that maybe using these might help with the skin involvement. And so this has been tried. So things like TGF-beta, which is associated with the skin fibrosis, interleukin-1 with rilonacept, abatacept for CTLA-4, and then interleukin-6 or anti-interleukin-6, which is which tocilizumab has been described as well. Now, another manifestation that is very, very common in patients with scleroderma is Raynaud's phenomenon. And this is present in more than 95% of patients with scleroderma. And this is classically described as a triphasic response or phenomenon that you can see. And so we think that this is caused by vasospasm that's occurring in blood vessels. As I mentioned before, there's a problem with the blood vessels in scleroderma. And so the blood vessels are not normal blood vessels. And when you get spasm of the blood vessels, in addition to, in response to a particular stress in abnormal blood vessels, then you can get loss of the blood vessels feeding the fingers and this kind of change that we describe. And the typical triggers are cold temperature. Certain medications can predispose you to this as well, and then also stress. And so the reason why it's triphasic is because it goes through typically 3 different colors, and it can be explained by just the biology of what's happening. And so you get initially vasospasm, so the blood vessels will constrict. And so there's a lack of blood flow going to your fingers, so the fingers turn white. And then after that, the tissue is kind of, because of the lack of blood flow, the white will eventually turn blue. We call that ischemia, so lack of blood flow. And then after that, when you rewarm your hands, then we get what we call reactive hyperemia, which is when something is ischemic and then gets rewarmed acutely, it turns red. And so the triphasic kind of color change that we experience is white, and then blue, and then red. Although a lot of patients will say that they don't necessarily experience all 3 colors, they may get a biphasic kind of response. And very, very classically for Raynaud's, as the photo shows above, it's a pretty sharp cutoff where it's occurring. So you can see very clearly where the Raynaud's phenomenon is occurring in the fingers and where the skin is normal. Now, in terms of prevention and treatment, because we know that there are certain things that trigger Raynaud's, we want to, of course, avoid as much as we can these known triggers. So avoiding the cold as much as we can, dressing in layers to keep the core body warm. And the reason for that is because the body is very smart. And when the body is cold, it will preferentially choose to shunt blood away from your fingers and your toes to try to keep your heart and your lungs warm, which makes sense. However, what we want to do in scleroderma is to keep the body as warm as possible, so the body doesn't feel like it needs to shunt blood away from the fingers and the toes. So not just wearing, mittens and warm socks, but also keeping the body warm. Smoking cessation, because smoking is a known vasoconstrictor, and then avoiding things that can cause more constriction of the blood vessels, like caffeine, certain decongestants, stimulants, like medications used to treat ADHD. And then in terms of active treatment, first line, it tends to be calcium channel blockers, things like nifedipine or amlodipine we use very commonly. If that's not enough, then we will add things like angiotensin receptor blocker, the ARB. Some certain antidepressants can also help with the inflammation and the vasoconstriction, and then topical nitrate as well to help open up the blood vessels. And then what we've been using also more and more are phosphodiesterase 5 inhibitors. And those are things known under the brand name of Viagra, for example, but we use it in smaller doses. The generic name is sildenafil, to open up the blood vessels in the fingers and help with the flow. And then we also can use sometimes botulinum toxin injections directly into the fingers, and that helps with the nerve endings that are feeding the blood vessels, all to try to help increase flow in the fingers. Another thing we see associated with Raynaud's phenomenon is nail fold abnormalities. And so patients with scleroderma will frequently have, if you take a look kind of around the fingernails, changes in the fingernails. And if we look with our dermatoscope, which is a special magnifying glass we often use in dermatology, we can see that there are abnormalities in the blood vessels as a manifestation of the blood vessel abnormalities we see in scleroderma. And so these are normal blood vessels, and you can see that they're a little bit curly, but generally speaking pretty straight, kind of going upwards to where the nail is. So this is kind of the cuticle, and this is where the nail is. And in active scleroderma, you can see that the blood vessels are highly abnormal. They are dilated, very large compared to the normal blood vessels up above. There's areas where there's no blood vessels because the blood vessels have been collapsed. And here another photo showing you, we call them dilated blood vessels. They're tortuous looking, kind of like this. And there's areas where there's no blood vessels, avascular. And the response to that is we can also see cuticular thickening, or the cuticle gets thickened, and patients may complain that they need to get manicures, or they feel like they need to cut their cuticles a lot because it's thickened. And you can also see, even without the little magnifying glass, that the blood vessels are not normal in this area. Another manifestation often associated with Raynaud's as well is skin ulcers. And typically the ulcers are occurring over the fingers, and we call those digital ulcers. And this definitely represents a source of great morbidity in scleroderma. It can cause a lot of pain, a lot of functional issues. And there's 2 main types of ulcers that we talk about in scleroderma. So there's one kind that occurs over the bony prominences, as you can see on the photo here. It's occurring over the knuckle areas. It can also occur over the metacarpal phalangeal joints. excuse me, typically in sites of trauma. Can also occur in other bony prominence areas like the elbows and the knees as well. And this is because patients with scleroderma have very tight skin. Sometimes they also have contractures over the fingers. And so when they bang themselves, even small trauma can open up the skin. And because the circulation isn't good, it can lead to a chronic wound and ulcer. The other place we see digital ulcers is on the fingertips. And this is the one that's associated the most with Raynaud's phenomenon, because this is more of an ischemic process where the blood flow isn't normal to the fingertips. And so when it's more mild, or when the ulcers have healed, we can see these little digital pits, we call them, more on the tips of the fingers. But we can also see large ulcers that are occurring, and these can be very, very painful and hard to heal. And so in terms of, prevention and treatment, a lot of it is the same as what we talk about for Raynaud's disease in terms of prevention. We want to try to treat the ulcers more gently. We don't want to be very aggressive in terms of the way we kind of remove the scale, and because then you can end up with an open wound that will take a long time to heal. In dermatology, we use a lot of specialized dressings that we can order with the insurance that can help also heal the wounds. It can also create a cushion for patients that tend to have more traumatic wounds to help those heal and to also protect the skin. And sometimes using things that help with the blood flow, like anticoagulants, can be helpful. Also, we want to be very mindful of pain control, and then using antibiotics if the lesions become infected. And then also preventing trauma is very, very important. And now I'll leave it off for Dr. Gonzalez, who will be talking about the second part.
Are you all able to see my screen? We're good? Hi, so I'm going to be speaking about other cutaneous manifestations that we commonly see in scleroderma. Going forward from what Dr. Lamb said, telangiectasias are small blood vessels that are dilated or widened, and they become visible near the skin surface. More common in patients with limited scleroderma, but they can definitely be present in patients with diffuse scleroderma. They most often involve the face, the lips, and the palms, but they can also affect mucosal membranes. And if you can see in these pictures, they're basically, you can find them everywhere. I want you to note the difference between the appearance of these ones versus this one. They're different types of patterns. They can be linear, they can be arborizing, or they can be spider-like, like the one you see here, which are definitely different from the ones that we typically see in scleroderma, which we call mat or matted. And the importance of telangiectasias, besides it being aesthetically unpleasing for the patient, is that its presence has been associated with manifestations of pulmonary disease or pulmonary vascular disease, particularly developing then to pulmonary hypertension. So it is important for us to note the presence of them, and then watch out for the development of any other organ manifestation. Unfortunately, there isn't much in terms of treatment, but we do have some lasers and called the pulse dye laser and the intense pulse light that have been shown to help with the appearance of the telangiectasias. We have no treatment to actually prevent them from occurring or reoccurring once we treat them with these lasers. But what these do is that they basically damage the blood vessel, and the blood vessel then collapses, scars, and this inhibits blood flow from going forward, which is basically what causes us to see that blood vessel. And then once we start treatment, patients need to be aware that there are going to be many sessions needed for these to improve. most times just one session is not going to be enough for us to see the disappearance of them. And then once they're treated, as I mentioned, the chance of them coming again is pretty high. Sorry, so next one, I'm going to be talking about pigmentary changes, which they can be really frustrating for many patients, and I see some of them, some of you already mentioned in the chat. So there are several patterns of the dyspigmentation. They are commonly observed in areas of sclerosis or skin tightening, but they can definitely be also observed in areas without such sclerosis. As I mentioned, there are several patterns, but two of the most commonly observed and described are the vitiligo-like depigmentation with sparing of the pigment surrounding the hair follicle, which we call the salt and pepper skin. So you can notice here how the appearance of the skin looks like salt and pepper. This would be a closer look. And this is basically the area has lost its pigment, but around the hair follicle, there has been sparing of it, which leads to this particular appearance. Another pattern is the diffuse hyperpigmentation that we can observe in these pictures, with some accentuation in sun-exposed areas and sites of pressure. The reason why we get hyperpigmentation in scleroderma is still not clear, but we believe there must be some dysfunction with the production of melanin, which is the substance that creates pigment. So in terms of prevention, we need to talk about sunscreen. And I know that you have questions about this. So yes, using sunscreen every day. And please don't be like me, that I just kept my sunscreen on my purse and I was really excited because I was using sunscreen. No, you have to use the right amount. You have to apply enough. It has to be applied several times during the day. It needs to be broad spectrum, meaning that it covers both UVA and UVB sunlight. And the SPF is recommended to be 30 or higher. The higher, the better. You can also use photoprotective clothing as part of your sun protection because many times sunscreen is not enough. Talking a little bit more about sunscreen, I do want to mention that there are two different types of sunscreen. There are physical sunscreens, but also chemicals. You can think of the physical ones as being exactly that, a physical barrier, like a shield. It goes into your skin and it is going to stay there. It's not going to be absorbed. It's going to sit on your skin, and it's going to be deflecting the sun's rays. The ingredients here would be zinc oxide and or titanium dioxide. The chemical sunscreens, they work more like a sponge. They're going to be absorbing the sun's X-rays. And they contain chemical ingredients, just to mention one, oxybenzone. These formulations are easier to rub in, but they're gonna, they don't leave the white residue just like the physical ones do. And they are not recommended as much for sensitive skin. If you have sensitive skin, you should be using more of the physical sunscreens. And the American Academy of Dermatology definitely recommends all of these, especially the water-resistant ones, to prevent skin cancer and worsening the pigmentation of your skin. Scleroderma patients don't necessarily develop more flares with sun exposure, but definitely some can be more sensitive to this. And also, as I mentioned, sunlight can make pigmentation worse. So we wouldn't be in a dermatology conference if we wouldn't be recommending sunblock. Sunblock for all as much as you can, always. Even if you're like driving in your car or just going out, we're always getting sun exposure, even if we don't think so. Another option that I wanted to bring up is that cosmetic makeup is really good to blend and camouflage pigment changes in scleroderma. The National Scleroderma Foundation has actually a really good resource for patients in their YouTube site in the virtual university. We have a makeup artist who is also a scleroderma patient that gives a lot of tips and tricks on different common brands and techniques that you can use to actually help enhance the appearance or actually hide any bothersome lesions. So I encourage you to go take a look if you want to learn a little bit more about that. Now going into calcinosis, unfortunately, this is another very common progressive and painful manifestation of scleroderma. It presents as dystrophic deposition of what we call amorphous, meaning no particular shape, insoluble calcium salts within the skin. Dystrophic meaning that you will see the appearance of these on sites where there was previous damage to the skin. We believe this is potentially related to mechanical pressure and microtrauma. The reason why we see the involvement mostly on the fingers, but also on your extremities. The elimination or perforation through the skin of these calcium deposits is going to appear as a white chalky material, and it can be followed by a persistent ulceration, which is unfortunately a very common complication. So how do we deal with the calcinosis? Again, this represents a very serious problem, and we still don't have a good treatment. We don't have a good therapy for it. There have been some studies that have tried several medications, including ones that dissolve calcium deposits like sodium thiosulfate, regulation of calcium mechanism with calcium channel blockers, or decreasing inflammatory pathways with low doses of warfarin and anticoagulant, but no definitive treatment. In certain situations, depending on the size and the discomfort, surgical removal may be necessary, although this is not the first line treatment, because we will be causing more trauma to the area, and we always want to prevent that. So at this point, what we aim for is basically to control the systemic inflammation and try to avoid trauma to the area as much as possible. So please don't squeeze them out. I know that many patients are really tempted to. And then avoid infections. Squeezing them can introduce bacteria to the skin, and once we get infection, chronic wounds, then it's harder to treat and heal. And now itching. I know this is one of the symptoms that most of you are really bothered about. It affects 40% of patients with scleroderma, although some studies indicate that even higher, and I'm tempted to believe so. It's mostly driven by dry skin, but there is also inflammatory and neurological pathways that have been associated to be part of this. Most commonly will be affecting the back, the arms, and the scalp areas, and many patients can describe this as being painful, burning, stinging, or prickling. Interestingly, different to other manifestations that we just presented, they can be associated to the autoantibodies that the patients present in their lab tests. And they can correlate with the clinical features. But itching in particularly has not been found to be associated or significantly associated to the presence of autoantibodies, and it's not related to the involvement of internal organs. So it seems that patients across the board, regardless of their manifestations or if they have internal organ development, they suffer from itching regardless. So very important driver. So dry skin is gonna itch. And very importantly is to avoid scratching. I know this is like asking an impossible thing because it's so tempting to scratch. So whenever we feel that itch, it is absolutely normal to feel like we scratch. When we scratch, the body is going to release some feel-good hormones, but it's also going to release some chemicals that are going to actually continue the itch. And it's going to become a vicious cycle where the skin can become raw. It can even bleed. We can then develop wounds, infections. So this definitely is not something that we want to do. Now I'm going to go into dry skin care. Why? Because dry skin cracks and also potentially leading to wounds. And so we want to avoid any soaps with fragrances, hard soaps, no scrubs, nothing that is going to be harsh on the skin. We want to look for products that are fragrance-free, not unscented. Anything that says unscented, you have to watch out for because it could be that they added some chemicals to actually make it unscented. So those chemicals can actually be allergenic and aggravate your itch. Antibacterial soaps, we also have to be careful of. They're more drying, so they're gonna just continue your cycle. Moisturize as much as possible. We recommend our patients to apply immediately after the shower and after each hand wash. You should keep your moisturizer very close at all times. Most effective moisturizers are definitely going to be the ointments, but they come in all formulations. You can find them in creams and lotions. Dermatologists love petroleum jelly. It's cheap. It's very unlikely to cause allergies, but yeah, it's sticky and it can get into your clothing. So you can use it at night and cover yourself with old pajamas and old bed sheets so you don't get them all messy. And there are other alternatives available, but basically petroleum jelly should be enough for you. What happens if you have like very, very severe itch? Well, we have other alternatives, topicals, meaning that you apply them directly into your skin. Topical corticosteroids, you can use what we call the soak and smear technique, which is basically at night you soak yourself with water and then without having dried up, you apply your topical corticosteroid and then go to bed. In the morning, you can reapply it. And then in 4 to 14 days, usually most patients will find some relief of their itchiness. Systemic, some patients, especially if there is neuropathic, meaning dysfunction of the nerves component, gabapentin or pregabalin could be an option, although you have to be aware that there are some side effects, including drowsiness, weight gain, leg swelling, and blurred vision. There are new studies that have been looking into phototherapy with the use of UVA1 and the UVB to help with the itching. These have really good findings in the most recent studies, so they could also be an alternative for some of you that suffer from severe itch. You definitely have to discuss all of these treatments and therapies with your dermatologist and with your doctors to make sure that they are appropriate for you. So we got to the end. I would like now to open it up to questions. I know you guys have a couple of them that I answered, others I did not. Maybe Dr. Lam could also help us out here. Mm-hmm. Thank you so much.
Thank you. Okay, so looks like, okay. I also welcome patients to raise their hand if they want to, and we can bring them onto the stage. And so the pinned question I see here is, do we need to wear sunscreen every day? What about annual skin cancer checks with the dermatologist? Can we go to any dermatologist, or do we need to see someone with scleroderma experience? So this is a great question. I think that Dr. Gonzalez answered a little bit about the wearing sunscreen every day. We do generally recommend everybody wear sunscreen every day. Annual skin cancer checks would be good, particularly in patients, I would say, that are on immune suppressing medications, because we think that sometimes those patients would be more predisposed to developing skin cancers, and patients that have lighter skin as well, also higher risk of skin cancer. And if there's a family history of skin cancer, definitely a good idea. And I would say for just the regular skin cancer checks in general, most dermatologists are very well equipped to do full skin checks and can assess patients with scleroderma as well. Okay, another question here is, I have recurring papules on both my index and middle fingers at the proximal interphalangeal joint. I have the same bumps on my scalp. They occur intermittently, usually preceding or during a flare. They itch and are very painful. What are these? They last about 1 to 4 days. This one may be a little bit of a tougher question. It's hard to know for us in dermatology sometimes without seeing things exactly what they are, because there are things with patients with scleroderma that are scleroderma related. But one thing to keep in mind, just skin lesions in general, is that you can also get, the whole host of things that we see in dermatology as a whole that have nothing to do with scleroderma. So it's possible that this is scleroderma related, maybe little bumps of calcium, for example, though that would be a little bit rarer on the scalp, or it could be things like eczema, and that could occur in both locations and be itchy. And so that would be worth probably taking a look at with a dermatologist to see exactly what that is, so that can be treated. Oh, yes.
My question is about an itchy scalp. I find that in the summer, since it's been kind of hot lately, about 90 around here, I'm sweating a lot, and I need to at least rinse my hair off, and therefore my scalp is so itchy. Do you have any? I can't put petroleum jelly on my hair. It's not going to work. Besides which, I'll ruin all my bedding. Do you have a shampoo that you recommend, or 2 or 3?
Some of it depends on what the cause of the itching is. Sometimes the itching of the scalp can be associated with things that are not scleroderma related, things like dandruff, or what we call seborrheic dermatitis, where there's a little bit of inflammation like eczema. So in those cases, over-the-counter shampoos like Selsun Blue or Head and Shoulders, for example, can be helpful. There's also prescription shampoos that we use for that. And then sometimes also steroids, as Dr. Gonzalez mentioned, like steroid solutions, which we use on the scalp a lot because it's definitely much more palatable in terms of the texture, can also be used to help with the itching. Okay, I see another question here. How often do you recommend a scleroderma patient see a dermatologist, and do all dermatologists learn about scleroderma in school? Great question. I think that in general, most patients with scleroderma should probably see a dermatologist at least once, getting a good skin check. And so, they can see whether there's anything in particular that's concerning in terms of precancerous lesions or skin cancer lesions. And then if there's anything in particular regarding, a lot of the skin manifestations, they can discuss that with the dermatologist. And then if there's anything, that needs follow-up, it can be things like on a yearly basis, or maybe even every 2 years if the skin is doing very, very well. And yes, in general, I would say as part of the training we all get in dermatology, we all learn about scleroderma. Although, you know, as Dr. Gonzalez can say, you know, there's extra training that we do as well for patients that have very specific manifestations that we do more targeted therapies for, and that sometimes is extra training. Okay, and then another question here is, would Juvederm be safe for cosmetically improving the disappearance of the lips? So I think this question is asking about the use of fillers, so cosmetic treatments in terms of scleroderma. And that's not something we talked a lot about today, because that would be like a whole nother topic in and of itself, which is cosmetic treatments in scleroderma. And so I think that dermatologists do use certain types of fillers and neurotoxins like botulinum toxin, for example, in patients with scleroderma. A couple things to think about would be, you know, there is a concern, sometimes maybe a little theoretical, that we can exacerbate the skin disease when we inject a foreign agent into the skin, particularly when the skin is active and not controlled. And so in general, we try to get patients to be controlled from their skin disease perspective before we do these kinds of things. But yes, it is something that can be considered for lip enhancement, for example. But I would suggest someone who has experience in doing it in patients with scleroderma. Okay, and then another question here I see is, fingertip ulcers are my problem. I feel like I can take care of them, keep them warm, wear rubber gloves when in water, wear lotions day and night. I cannot seem to get rid of them and have had them for years. Is there anything else I can do? I don't know if Dr. Gonzalez wants to jump in and add anything here. So fingertip ulcers, I would say, are very challenging. Digital ulcers is something that we see a lot in scleroderma. And it sounds like in this case, for Mary, you're talking specifically about more the ischemic variant, right? The kind that's associated with Raynaud's rather than the traumatic kind that occurs on the back of the hands. And so you're doing kind of all the behavioral modifications that we talk about. So keeping the hands warm, you know, decreasing the wet work as much as possible, keeping your hands well moisturized. But sometimes if that's not enough, then we talk about, you know, augmenting therapy with medications, like pills to help open up the blood vessels and the flow of blood vessels. So calcium channel blockers, sometimes things like sildenafil, which is a phosphodiesterase 5 inhibitor I mentioned in the talk, would also be something that we can consider if they're very recalcitrant and very painful. And then I see something here. I don't know if you all need to go to another session, but I can see that it's a little bit past the time. So maybe I'll have this be the last session, but I'm happy to stick around, or if anybody has any additional questions, Dr. Gonzalez and I can answer that afterwards. So can hyperpigmentation patches on the forehead fade or be treated? I would say that this depends a little bit about what the hyperpigmented patches are due to. So, you know, how we kind of talked a little bit about how you can get general dermatology issues occurring in a patient with scleroderma. This would be an example of that as well. And so hyperpigmentation can be due to scleroderma, but it can also be due to things like melasma. It can be due to things like lentigines or sunspots and freckles and things like that that are occurring. It can be post-inflammatory changes from a rash of something else. And so there's many, many different causes for hyperpigmentation. And so some of it depends on what the cause is so that that can be treated and then faded over time. Do you think I can still answer questions? I just don't know if you have sessions to go to afterwards, so I don't want to take up too much time. Yes, okay, perfect. Okay, I had some on my chest and was doing a UV light treatment at my dermatologist, and it actually went away for the most part. This was not what I was doing the treatment for, but a nice effect. I don't know what this is specifically about. Do you know, Dr. Gonzalez, is this about telangiectasia maybe? Or pigmentation?
So I apologize. It's like the questions are being in here, but I was following other questions down here, so are we addressing the one that's up here?
I don't know. If the person who, if Ilana wants to step onto the podium or raise hand, we can maybe we can talk about it a little bit more, just to make sure we're understanding it properly.
Hi, can you hear me?
Yes.
Would you be able to comment a little bit on the pain management, either orally or topically, for the calcinosis or the ulcers?
Do you mean specifically with regards to pills or with regards
to? So
yeah,
as this causing chronic pain, obviously trying to avoid opioids unless it's like an acute event. What are you seeing efficacy with as far as chronic pain management?
Yeah, that's a great question. And I would say a challenging one in terms of the management of it. And I agree with you. I think a lot of patients don't want to become, dependent on a lot of these medications and try to avoid them as much as possible. I think local therapy for us as dermatologists is kind of where we can intervene and hopefully try to help patients as much as possible. And so for ulcers, with calcium, that tends to be where when the calcium gives like ulcers, when it extrudes into the skin and leaves a chronic wound, that tends to be where the pain comes from the most, as well as, the digital ulcers from ischemia on the fingertips and the back of the hands. And so we do a lot of wound care with patients like that. We prescribe certain types of special dressings that you can get through your insurance company. And that can create either an antibacterial effect to help it heal if there's, chronic infection in those areas. Also, just sometimes keeping things covered instead of leaving them to the air can be helpful for a lot of patients because that is painful. Keeping things moisturized with good moisturizer also, because dry skin cracks and that also worsens everything. And then there are also specific kinds of dressings we use that are cushioned, and that can also help with trauma and protect, like kind of act as a barrier to the skin. And when patients will accidentally bang their hands or their knees on something, it can also protect them from creating wounds. And so those are kind of more local therapies that we can do to help with pain management.
Yeah, but we always definitely want to try to avoid starting opioids as much as we can. Those can have very deleterious side effects. Treatments that we don't necessarily use a lot but have been tried, anesthesiologists could try and inject the area with some local treatments. Botox at some point has also been tried, but we lack good trials in terms of that. So we definitely don't have like much in terms of alternatives. So in terms of digital ulcers, much of it is prevention and try to make the area as comfortable as possible, as Dr. Lamb mentioned. You do, though, whenever the pain becomes too severe, like an acute change that you suddenly develop much more pain than usual, do let your doctor know immediately, just to make sure that there aren't any new ischemic changes that would require further intervention.
Okay, and then next question. How long does it take to see results from sildenafil? Some of it, I think, depends on the dose of the sildenafil. So typically we start with a lower dose, like 20 milligrams a day, and then we can slowly increase it to about 3 times a day. And so in general, though, if it works, it's not something that takes months and months. It can be pretty quick, I would say, probably in the order of like a couple of weeks, especially for the pain. Yes. Deborah.
Yeah, there's 2 or 3 questions in the comments having to do with not just itchy scalp, but also hair loss on the head, but also other parts of the body. Could you talk about how common that is or isn't, and any suggestions?
I just want to make sure I understand the question. So you're asking about hair loss on the head, but also hair loss on the rest of the body associated with scleroderma?
Yes.
Okay.
Well, mostly I'm asking about the head, but I did notice that one other person talked about hair loss in other parts of the body as well.
Okay. All right. Thank you. So hair loss is, I would say, not a specific manifestation that we typically see associated with scleroderma. That being said, hair loss can occur from many, many different reasons. And some of those reasons are also shared by patients that have scleroderma. So it's definitely something we can see. And so some of it depends on the pattern of hair loss. So the way we approach hair loss in dermatology depends on what the scalp looks like, because you can get diffuse hair loss and where the hair, it's essentially a cycling problem. And so, you know, our hair cycles through growth phase, it rests and then falls out. That's just the normal cycle of hair. And sometimes that can get dysregulated because of stress. If you're very sick, for example, and hospitalized, and then the hair just falls out acutely and then grows back. But there are also diseases of the skin itself. Lupus, for example, is a very common one that I see in the connective tissue disease clinic, where the skin of the scalp is affected, or there's a disease on the scalp itself, on the skin. And that causes the hair follicles to be damaged in a particular way, and then that causes hair to fall. And so what can be helpful for that is, you know, looking at the scalp, I think having a good exam to see, you know, which kind of pattern it falls under. There's also, you know, probably more commonly in patients that have scleroderma, autoimmune diseases like alopecia areata. And so that's an autoimmune disease where your body attacks hair follicles, and it can attack hair follicles anywhere on the body, on the scalp, eyebrows, eyelashes, on the rest of the body. It doesn't leave scarring, so the skin looks totally normal underneath it, but because it's an autoimmune process that's attacking the hair follicles, hair falls out in patches frequently, and then you need to do treatments to help the hair grow back. Okay, so I see another question here that says, should we not consume anything with calcium if calcinosis is an issue? So in general, we don't really have any dietary restrictions from a calcium perspective for calcinosis cutis, you know, provided that patients are not, I would say, consuming an enormous amount of calcium, but in general, a normal amount of calcium or normal amount of vitamin D, you know, is not a problem. Okay, yes, Kristen.
Hi, I'm just curious. When you were talking about the itching, I'm wondering, there's some patches that like showed up around buttocks and back and hips. And I'm wondering if they're a manifestation of maybe some deficiencies with certain types of vitamins and such. I was prescribed the cortisone steroid treatment, but they don't go away. They still remain, and they still itch. And so I'm wondering if it could be related to, especially with on the buttocks, if it's, has there been any research about perhaps, because I have a really unique one. It's the scene Scleroderma, dealing more with my internal organs and such. And I wonder if it's coming up through the skin as a manifestation that there's difficulties happening in my body, which I already know there is. But is there any treatments apart from, because the cortisone doesn't seem to be working? Is there anything specific that might be, because it's kind of strange. It's like gray skin patches and more almost circular. And so I'm just wondering if it's related to perhaps deficiencies, like with certain vitamins. You were just talking about B12 and B and D, and I'm wondering with the vitamins and sun and such, I wonder if it's all related. Thanks.
Thank you. Thank you. Do you want to answer, Dr. Gonzalez?
So based on your description, I think it's a little bit difficult for us to know exactly if it's related to your scleroderma, especially if you're saying that you have the sinus scleroderma one. I'm not sure if the findings that you currently have are related or if they're actually another entity that might be causing it. You can also talk to your dermatologist because maybe the cortisone is not strong enough for whatever it is that they were treating, and maybe a stronger steroid might be helpful. But again, we have to first check if that is actually treating what you have. I don't know if Dr. Lam has any ideas, but I think that I can particularly say based on your description if it's related or not.
Mm-hmm. I mean, some other things to kind of think about would be, if a steroid doesn't work, is it something that's more maybe like in the realm of a fungal infection that can sometimes occur around the buttock area that wouldn't respond to a steroid. Other things that are more scleroderma related would be things like morphia. I think there was a lecture by Dr. Jacoby yesterday on localized scleroderma. That can sometimes be seen in patients with systemic sclerosis, where they get patches of fibrosis on the skin, but not kind of in the diffuse way that we see it in the systemic version, systemic sclerosis, and that can sometimes be itchy as well. So I think some of it just depends on the actual assessment and what it looks like, and sometimes a biopsy can be helpful in those cases to differentiate. Okay. So I think we're at time. I think I was confused earlier. I somehow thought the session ended at 3 and not 3:15. So thank you. I saw in the comments that people were saying that. And thanks to Lauren, who's our host, who's been helping. You can see our emails up on the screen. If anybody has additional questions or anything else they would need, we're happy and available to answer any of those. But thank you so much for attending the session. We're really happy to be here and speak about the skin and scleroderma. Thank you.